Great. Looks like we are live. Good morning. I'm Justin Mauger. I'm the community health educator for Central and Eastern Washington for the Washington Poison Center. I want to welcome everyone back. Thank you for joining us for the Louisville Quick Response Team, a harm reduction approach to post-overdose visits with Cillian Browne. But before we begin, just quick housekeeping reminders. This series runs with a new speaker and topics every Tuesday this month. We still have tickets available, so don't hesitate to invite folks. If you value what you're hearing and seeing here, please share it with people. Again, thanks to our sponsors. We work for Health Washington, the Washington State Department of Health Drug User Health Program and Teen Health Hub, the Washington State Healthcare Authority, and specifically the Friends for Life program. Again, this is our first year at the series where we have sponsors, so we really do appreciate our early adopters. Additionally, as participants who are tuning in, you're muted, so please direct questions and comments to our chat box. We will have an opportunity to address questions towards the end, so just whenever you have them, just pop them into the chat box and we'll get to those towards the end of the presentation. Finally, if you want a certificate of attendance, you'll need to take a survey that will be emailed to you from HUVA at the end of the series. Alas, it's my pleasure to introduce Cillian Browne. Cillian grew up in Kildare, Ireland, where he learned and developed his skills in the hospitality industry, which eventually took him to Louisville, Kentucky. With stints in hospitality, construction, and the healthcare industries, Cillian found himself volunteering at Louisville's syringe exchange program, where he was hired on as Louisville's first ever full-time quick response team employee in 2021 and helped build their team up to where it is today, ingrained and trusted in Louisville's community. Cillian has 7 years in long-term recovery and stays active in his community. Cillian, thank you so much for joining us today to share about your work. We appreciate the opportunity to learn from your experiences, and I'll hand it over to you.
Awesome. Thanks, Justin. Thanks very much for the introduction. I'm very grateful to be here. I was just telling Justin that I stumbled across Washington Poison Control or Poison Center a few years ago, read a couple of articles and just really enjoyed what I was reading. And so from there, I just subscribed and I've been getting the newsletter ever since. I was grateful and lucky enough to be able to go to the Overdose Awareness Series last year to one or two webinars. And it's just packed full of solid, good content. So to be able to present is an absolute honor today. Basically, I'm the community health supervisor on the quick response team. We follow up with community members who've experienced an opioid overdose, just provide a wellness check for them, see how they're doing, and if they need help with anything at all. So I'll jump right into it. The quick response team model. Original model is like to provide a wellness check after a possible opioid overdose. That wellness check's usually completed within a period of time, anywhere between 24 to 72 hours. And it's usually conducted with a team of anywhere from police officers to clinicians, social workers, and even peers. The overall goal of a quick response team is aimed at reducing overdose fatalities. And again, offering any connection to services and resources if requested. So like that if requested part, we always practice a harm reduction mentality, like is in the heading. And so we have to we kind of got to leave our pride and ego at the door. We may think we know what's best for somebody, but at the end of the day, they're the experts in their field. So for us to show up to people's houses unannounced and tell them what we think they need to do usually isn't going to go too well. The quick response team was created in Coleraine Township, Ohio in 2015, and it was a collaboration between Colerane's police, fire, EMS, and addiction services to reduce the number of overdoses in their community. The Coleraine Township of Ohio, in a few short years, had responded to over 250 follow-up incidents with an 85% rate of follow-ups being connected to treatment services. So what does it look like for us here in Louisville? It initially started as a collaboration between Louisville Metro Police Department and Centerstone Behavioral Health Services. However, there were some barriers to this mode, including Louisville's racial justice uprising. And of course, the COVID-19 pandemic, this brought in huge barriers to them to be able to function efficiently. And so also they just had a pretty hard time engaging with community members. So obviously it wasn't a great time for police officers to be showing up knocking on people's doors. So uh, today the quick response team is housed. My screen's after going on me. Can you guys still see my screen?
Yeah, we can see it.
Okay, I'm having technical issues on my end. Um, sorry, I lost my train of thought there. Our quick response team is housed in the health department, and this wouldn't be possible if it weren't for Dr. Amanda Foley Boyd, who was the former treatment implementation specialist for the Kentucky opioid response effort. And she developed a super innovative proposal to house the quick response team within the health department. So in July 2021, the Louisville Quick Response Team within Louisville Public Health and Wellness was formed. And just last month, we celebrated 4 years of successful operation. Although some days didn't feel successful, overall, it's been an absolute success. Unfortunately, less than a year after forming, Dr. Foley Boyer passed away. And so we are super grateful that we're just able to do this work in her honor. Over the years, we've seen the program grow from increasing the number of referrals that we receive each day or each year to continuing to just build incredible relationships with both community partners and community members as well. Real quick, we could take a look. This is a map of Jefferson County, and you can, kind of draw a line straight down the middle. And on the, northwest, west, southwest, and south of the county, we can see drastically larger rates of fatal overdoses. These are predominantly low income neighborhoods and more prone to substance use. So, obviously we spend the majority of our time up and down this side of the county. And this map just kind of outlines a drastic inequity within our county. Next, we have a table of Kentucky counties with the highest rates of overdose deaths in 2022. And as you can see, top in the list is Jefferson County, where we operate, with a drastically higher count. Obviously, our county has a drastically higher population. Um, so, yeah, we're just super busy every day, unfortunately. Um, we are core funded, so Kentucky QRTs in all of Kentucky are made possible by the Kentucky Opioid Response Effort, or CORE. CORE seeks to sustain a comprehensive and recovery-oriented system of care to end the opioid epidemic that has reached into Kentucky communities. CORE is federally funded from SAMHSA, and supports evidence-based prevention and treatment and recovery. Core funded partners and services model policies and practices grounded in best practice and compassion. So just a little bit on our data sharing process and how it works. Within Kentucky, data is able to be shared with us, thanks to the Kentucky Revised Statute, which allows emergency services to share Narcan-related data with us at the health department. So we receive most of our referrals from Louisville Metro EMS, Louisville Fire Department, and hospitals. We have an absolutely fantastic, amazing team of epidemiologists that are able to receive, manipulate, analyze the shared data, and then they transfer that data over to us, the QRT, in legible form, and we receive that daily list. And it often comes with varying levels of information provided. Some barriers to this process include missing or unused data, like missing apartment numbers or addresses, missing phone numbers. We're given bad addresses sometimes. If somebody is picked up at a street corner, we'll be given the street corner as a pickup address. And obviously, it just makes it a lot more difficult to connect with that community member. Also, we have missing names as well, which I'll discuss later on how we approach those situations. So, what does it look like when we're in the field? Well, we operate Monday to Friday in teams of two, consisting of peers with lived experience. And oftentimes we try to send out two teams in a day to just, cover a wider reach in the community. Unfortunately, we receive a lot of referrals, so we definitely have the ability and the need to send out more than one team if possible. Um, it's super important for us as a team to be able to create, a non-judgmental, destigmatizing experience for the person that we're visiting. We aim to build up trusting relationships with our community members, which includes repairing broken relationships between our community members and the government. I don't know about you guys. Like I'm in the category of people who don't trust the government. And we're fully aware that we are the government. So when we show up to people's houses and we have our little blue badge, people see it and they automatically are like, nope, I don't want to talk to these people. And I get it, I understand. Like if the government called to my house right now, they're not there to give me a prize or tell me I'm doing a great job at life. Like in, more often than not, something bad has happened. Um, so we receive a lot of like initial reluctance to engage with us, and when we lean into a couple of sentences and talk about our lived experience, the majority of the time people just open up and chat with us. So we always offer a connection to any resource, not just substance use related, but anywhere in life that somebody may be struggling, right? We always aim to help them. We're not going to leave them and say, well, listen, if you ever have another problem with substance use, give me a call. But until then, we'll see you later. So like food, clothing, employment, education, housing. Um, like I'm going off script here. I'm reading everything to you, by the way, but through my notes. But when we call to people, I'm sure you guys witness this as well in your communities. Like folks are like in a situation where, they may have used one or two times. They might not need to go to treatment. They might not have any want or need to go to treatment. But something that they are struggling with in their life could be any other social determinant of health. So as public health representatives, we absolutely see that it's our absolute due diligence to show up, um, and represent and aid and assist the public, especially if they're asking. So it's the absolute least we can do. More often than not, we give them the answer of like, I'm not sure where we find that, but we're going to help you find that, right? Um, and when people genuinely see us come with that care and compassion, um, it enables them to trust us a little bit more, and we're just slowly building up that relationship with community members. We typically see more family members than we do people who've experienced overdose, and these conversations can be super difficult, and oftentimes heartbreaking, but they're really, really necessary to have. Um, Support for family members of people who are using substances can be lacking. And if we're able to, even begin to fill a part of that void, then we absolutely will. So something that's come from the QRT is seeing this gap with family members. So we always talk about like an overdose as a traumatic event, and that traumatic event like is like a ripple effect. It spreads to families and loved ones. And I bet if I see everybody's head in the crowd here, I'd see people nodding along with it. So I know I'm preaching to the choir. So instead of leaving them where they're at, we're going to continue to try to help them. And we develop like brochures to support groups for people who've lost a loved one to an overdose, or have somebody in their life struggling with substance use. And just having that compassionate conversation with family members really goes a long way. Oftentimes their shoulders drop, and at the end of the conversation they just say like, thank you for listening to us. um, an angle of approach that we always adopt when we talk to family members is just pausing and asking them like, hey, how are you doing? Oftentimes they're like trying to hold it together. They have multiple family members that might be struggling. um, they're trying to be like the rock in their person's life, and it can be hard on them as well. So chatting with them is a super important kind of trend that's come out of initially aiming to just reduce fatal overdoses and connect with people who are using substances. Um, and then we often carry follow-up visits as well. And the follow-up visits is really where the trust can grow, because once people see us come back, not because we have to, just because we want to, and no consequences have happened to them in their life. CPS haven't shown up, they haven't got kicked out of their apartment, their employer hasn't fired them from their job, the parole officer isn't calling them, like nothing at all, except we come back and ask them how we're doing. They really start to open up a little bit more. And that's how we just keep the conversation going, and we can just continue to become, if not now, then maybe later on, we can still be the person they go to when they're in a tough situation. Whether it's substance use or non-substance use related. So, we've really become the middle person between a community member and the resource that's available. And that community member doesn't know the resource that's available. And I always explain it like the community member is a set of Christmas lights, and the resource is a set of Christmas lights, and we're just plugging them in and turning all the lights on, and everything looks nice and pretty. And then we get to move on to the next place. Um, I love Christmas, by the way. I came up with that analogy at Christmas. Um, okay, so yeah, we carry follow-up visits. Something we've also noticed as well, and this is probably for me the hardest conversation. We'll call to visit Cillian. Cillian's parent answers and says, "Hey, Cillian isn't here. He passed away 2 days ago from an overdose." So in that moment, we'll kind of read the room a little bit and see how the conversation might go. But we'll always carry out a 2-month follow-up to those family members. And this is definitely something we don't have to do within our job description. But again, it's like we genuinely care. And our hearts break when we have these conversations with community members. So when we show up 2 months later, I'm sure you're all well aware after any sort of death, me and my family were flocked with people bringing over curries and lasagnas, and they're there for us. But eventually, people go back to their lives, and the dust settle, and the family members are left to pick up the pieces and carry on. Um, and that's just hard, right? In all walks of life, any sort of death, any sort of type of grief is just difficult. So we can show back up and chat to them, and just offer any sort of support. Some of them are already in therapy, some of them are not, but they're interested. Some of them have fantastic support group around them. Some of them don't. Some of them have even informed us of some support groups that we didn't know about. And I was able to go to some of them support groups, and I'm a person in long-term recovery, and I practice like a 12-step program. That's what works for me. It doesn't work for everybody. And I went to some of these support groups for family members who lost a loved one, specifically to an overdose, and just some of the toughest conversations I've witnessed, um, and some of the most incredible like strength and growth that I've witnessed as well. So being able to connect people to them is really cool. It really fills a cup. Um, but they're very difficult conversations to have. But again, like this is happening in our communities. Like we would much rather have these awkward, uncomfortable conversations and tough, difficult conversations than kind of bury our heads in the sand and pretend like we don't need to. So I touched on it a little bit earlier, but it's just astronomically important that we uphold the confidentiality and privacy of the community members whose information we have. Um, I mentioned earlier that like Metro EMS and Louisville Fire Department, they have agreed to, they don't have to, but they've chosen to be really nice about this and share the information that they have. So EMS or fire respond to a possible overdose, and they get on the scene, they use naloxone, and then they either transport the person to a hospital or they don't, and the person refuses transportation. But that's the information that we get. That data is not our data to share, right? So I'm not allowed present at this presentation. And I can give you like numbers, but I'm not allowed to give you specific information. So for us, it's super important to uphold that data. Um, the share. I lost my train of thought here because I'm getting into it and I'm getting excited about the things we're talking about. Importance of our confidentiality. Conversations can look different depending on the level of referral that we get. So sometimes the information that's given to us will include, a person's name, where they were picked up, their home address. It can also have primary and secondary impression from EMTs. It can have like a whole list of information, and that's great. Sometimes all we have is a pickup location. We don't have a name. We have a date and a pickup location. And again, that's not a lot of information, but it's still information that tells us an overdose may have taken place at this location. So if we have a name, we can go and say, hey, we're a health outreach team. We're here to follow up with Cillian Browne. And if we don't have a name, we'll say, or sorry, not follow up. We're here to connect. We're here to see if we can connect with Cillian Browne. And if we don't have a name, we just say that we're a health outreach team and we follow up with ambulance runs or medical emergencies. And all we're trying to do is check and see how folks are doing. Um, More often than not, everybody says, I'm fine, I don't need anything, thank you, goodbye. We can really quickly just say, hey, we offer Narcan to anybody we come across. Um, and once we mention that in the lock zone part, the door swings back open and people are like, wait, you got Narcan on you? And we're like, yep, we sure do. And we got plenty of other stuff in the car. And then again, the conversation just starts flowing. We can slowly drop in our lived experience. I think I have it mentioned in a slide later on, but like we're pretty disarming people. I'm like 5'7", 130 pounds. I've seen more meat in a pair of handcuffs. Like we don't give off cop vibes at all. And initially it comes across as like kind of maybe social workers or like authoritative figure talking with a community member. And very quickly we've gotten really good at like just breaking down those barriers and just having it be two people just shooting the breeze on someone's porch. Um, and that all comes from like just a heavy, non-judgmental, non-stigmatizing approach, talking about our lived experience. Um, and it really changes their body language. And it's just an awesome situation to happen. Um, all conversations are confidential. And again, we mentioned this to people. I come across people I know from outside QRT, and I'll always mention to them like, "Hey, I'm not going to tell anybody about this." Um, if we're making a referral, we'll always try to do so in the moment. So we'll stand with them on their porch or in their home. We have great connections around town, which I'll speak about later. And instead of saying like, "Hey, here's a number you can call that's going to help with that," instead we know the person at that location, at that organization, and we can say, "Hey, if you want, I can call my friend so and so who works there and see if we can get you connected, right?" And they're always like, "Oh, that'd be great. We'd love that." So they're starting to buy into trust with us. And then if they see us like be transparent and do what we say we're going to do, and then we trust other people, they'll be like, "Well, if Cillian trusts this person, I'll be more willing to trust them." Also, like making the phone call with them is a massive help, you know. I always make the reference of like my dentist is usually always on my to-do list of people I need to call, and I never do it. She always gets bumped down to the bottom. Um, and if somebody came in the door right now and said, "Hey, Killian, I got your dentist on the phone," I'd be like, "Oh, brilliant! I need to talk to him." You know. So sometimes we're just planting that seed. We never try to push them if they don't want to do it. But if they do want to do it, we'll absolutely help them do it. Um, so here are some stats. Over the years, in 4 years, we've gotten about 7,000 referrals. We've connected with over 800 community members and over 1,300 family members. Um, 800 community members who have experienced an overdose and over 1,300 family members. We distributed over 3,000 units of Narcan in QRT alone. That number is a lot bigger when we factor in community events, Narcan trainings, things like that. And then over 1,000 fentanyl test strips. And we've referred over 300 people to treatment. Switching over to look at some more graphs and stats and data that our EPI team have been able to give us. On the left, you can see about a 13-year period of death rates in Jefferson County between both our white community, white residents, and our black and brown community. And then just a quick highlight in 2019-ish. Probably 2017 to 2017 onwards, we can see like a drastic increase in our BIPOC community. And then again, switching over to the right hand side, um, yeah, just 2021, we saw a massive increase in our black and brown community for fatal overdoses. And this kind of spurred on our heavy naloxone saturation program to specifically focus on those areas. Around the same time, we started to see a slow and steady decline in overall fatal overdose in Jefferson County and as well in our white communities. And I'm happy to say that in 2024, we have seen a slow and gradual decline in our BIPOC communities for fatal overdoses, um, which is, a huge effort that we focused on. I'm not going to take credit for it, but we did a lot of work in those communities. We made a lot of great connections. Had a lot of fantastic conversations as well. And so it's just really nice to see those numbers drop. Fatal overdoses in Jefferson County from 2016 to 2023. Again, massive bump, massive increase in 2019. About 2 years later in 2021, we started doing our thing. There's a lot of people in our community that have been doing this a lot longer, from syringe services programs to Kentucky Harm Reduction Coalition. Like, I'm not taking credit for any of this, but it's nice to be a part of the fight and the struggle, and then to see numbers like this come down. It's good. There's still a lot more work that needs to be done. Our local epidemiology team put this together, so it's split up on quarters from 21 to 25. And it's pretty this is quick response team visits where contact was made. So contact can be anybody at all, from opening the door saying, no, I don't want to chat with you, to inviting us into their home, to we show up to the place and turns out it's actually a business and we talk to the business owner, and he either does or doesn't want to take Narcan from us. Um, Note in 2024, January 2024, massive increase. This is one of the many times that we've increased our referral process. And so I remember back then we almost, like, just about got our head above water coming into Q4 of 23, and we were doing like a ton of follow-up visits and just connecting with a lot of people. But look, in the back of our mind, we knew there were more overdoses taking place. So we regrouped with some community partners and were able to often double, if not triple, our referral process in early 24. So once again, our heads were resubmerged. Eh, Um, but look, we were able to manage, pull up our bootstraps or whatever you want to call it, and just continue to hit the ground. So, yeah, pretty cool to see this. And then again in Q1 of 25, we saw another increase. Again, we started to receive more referrals from a local hospital. So that kind of encapsulated more mental health crisis than just opioid overdoses. So we have started to see a lot of people. I was chatting with Justin earlier. People who may have ingested the wrong amount of edible gummies, or taken too much psychedelic mushrooms. And so, although they're not experiencing an opioid overdose, these are still community members that may or may not be in crisis. And it's our due diligence as public health representatives to really try to show up, um, and help them in any way possible if they want it. So just a little bit about our harm reduction approach. We really try to meet people where they're at. I know I've spoken about this a little bit, as far as, somebody might have been on our list 3, 4, 5 times. I might, I would love it if they, would go to treatment. And if they don't want to do that, that's totally fine. Um, we really have a non-judgmental approach. People have gotten to know us and we hear like, oh, I knew you guys were coming because I overdosed last week. I'm sorry I did that. I know I shouldn't be doing it. And that level of guilt, shame, and embarrassment is just like, front and center for those folks. And as someone in recovery, like, I've been there before, like, that guilt, shame, and embarrassment is something that I live with as well. And so we always just try to reduce that stigma and just, chat with them, not as, um, like any sort of clinical expert, but just as like someone who gets it, and more often we're just like rapping about, usage and in and out of recovery and not being able to get it and trying and not trying things like that. And that's where the compassionate client-centered services and referrals come in. So again, we're chatting with people, meeting them where they're at. We build up rapport and trust with them. We've been in touch with people for I started in September 21 and I met this young guy in October of 21. And we still see him regularly, and him and his family are just fantastic human beings. Um, and we just continue to show up for them, because that's what they deserve. We develop connections with people who aren't receiving any services, help people stay alive help people who use drugs stay alive. So, look, people are hard on the person who brought me into this world and taught me a lot about what I know, said Cillian, nobody is as hard on themselves as people who use drugs. And so, seeing people look at us when we offer them Narcan or test strips or clean sterile syringes, it instills hope and positive change. But it gives them like just gives them hope, We're not talking down to them, we're not talking at them, we're not telling them what to do. We're just there supporting them, whatever choice they want to make. We're just there to support them. We offer or we approach free from judgment, coercion, and discrimination. And we don't require anybody to stop what they're doing. There's a lot of places in the world that are like, hey, we're here for you when you get to this level. When you're at this level, you come see us. And so our harm reduction approach is like, look, we're here for you no matter what level you're at, no matter where you're at. We understand if all you want is Narcan so you can continue to use and not overdose, that's great, Let us help you. We'll give it to you. Um, we've also seen over the years a lot of people will be like, hold on a minute, you, the government, are going to come to my home and give me a tool that's going to help me do drugs. Yeah, I don't think so. And so they would have us, meet them in parking lots and alleyways, um, which is pretty funny. And then over time, they'd get to know us, and I'd say they'd call me again and say, hey, can I get more Narcan? And I'd be like, yeah, you want me to meet you in the alleyway? And they'd be like, no, you can just come to my house. It's cool. And so that's where like the slow trust and relationships get built up. So this is what it can look like for us in the field, right? We can give people things like naloxone, give them fentanyl test strips and xylazine test strips. We can give them clean sterile syringes, link them to services, educate them, right, on safer using practices. So again, we had a young man who was continuing to inject in his arm, in his hand. He was using the wrong size gauge. His hand was swelling up. So we were able to sit down with him, open up a bunch of different syringe packets, talk to him about, his option to switch from injecting into a small vein in his hand to like moving up his arm and hitting a bigger vein. He'd have more chance of hitting the vein. Um, Therefore not wasting his drugs, not doing further damage to himself, showing him how to properly inject, clean the area, and he was like, "This is crazy. Why are you guys telling me this?" And we know, right? Like if we don't show him that, he's going to continue to use in a more harmful way. So, it's better that he uses safer than use not safer. Um, and then, we talk to people, we try to educate them about the drug supply. Definitely in the early days, we had a lot of people say, like, no, 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 Killian, I didn't overdose. I just hadn't slept in a while. I've been using methamphetamine. And then I took a Xanax. And then I don't know what happened. And I woke up and there was blue and red flashing lights all around. And so we were able to educate them in that moment of like, hey, look, 4 or 5 years ago, you would have been right. The drug supply has completely changed. Like, had you taken that counterfeit Xanax back in the day, it probably would have had the same similar feelings that a regular Xanax would have. But the tainted and poisoned supply has just changed to where it's laced with fentanyl. You don't have a tolerance for fentanyl, and that's probably why you may have experienced an opioid overdose. So having that conversation with people was really eye-opening for me and them as well. I remember back in the day, we had really we had really seen the trend in fentanyl showing up in counterfeit pills. And then I think it was maybe 4 or 5 months later, the CDC officially came out and said, "Hey, we're seeing this trend as well." So, we were noticing these things in our community before they were even being spoken about on major global websites. Um, so, I mean, looking back, that was pretty cool. It wasn't cool at the time. Um, we always talk to people about, look, if you're going to use, these are tools that can help you use safer. These are also ways that you can use in a safer manner. Telling them about the Never Use Alone website or having them use with someone. Start low, go slow. Instead of using a small amount, or instead of using a big amount or your regular amount, ease into it slowly and see the effect that it gives you. Stagger your usage. So if you are able to use with somebody, let them use first or you use first, and they can see the effect that it has on you. Because if you both do it at the same time, you can both jump in, and then, both nod out and experience an overdose. And then switching mode of use as well is always an option for folks. If they want, they can switch from injecting to snorting, or snorting to smoking, or anything like that. So these are all small, subtle ways. When I have this conversation with folks on this platform, we get it. We have these conversations at like schools and businesses, and people's minds are blown. And so we really shift the conversation of like, we're not teaching people how to use drugs. And there's definitely a stigma and a myth around harm reduction of like that's what we're doing. And we simply say, hey, look, I can guarantee you they're using them, whether we show up and chat to them or not. Um, so some pros and cons. Everything. We are a peer-led team, and so that can come with some pros and cons. Some benefits to being a peer-led team. I mentioned some of these before. We can provide compassionate, empathetic approach through our lived experience, having once felt similar lows and pains. And really, this is our strongest tool, and can really quickly help remove some initial barriers. We had an old co-worker, Samantha, she won't mind me using her name. She still is awesome, but the way she would like lay out that 1 or 2 lines, it just blew people's minds. She would say like, yeah, like I overdosed 10 times a week. I got sober. I wouldn't be here if it wasn't for Narcan. And that sentence alone, coming from her specifically, really helped shift a lot of naysayers to like yay sayers, is how I like to explain it. Once they chat with Sam, they're like, hey, you know what? I think I will take some Narcan. So that was always cool to see. So yeah, speaking with people on our lived experience would really help remove some barriers like stigma and shame, right? So people may feel, uh, that guilt, shame, and embarrassment, but once we talk about who we are, they didn't feel that as much, and they were able to kind of like you'd physically see them stand up more straight, and they'd lift their head up, and they'd make eye contact with you. That's a beautiful thing to see, but it's really sad to know that they don't always feel comfortable um, expressing themselves in that way. Again, I mentioned we come across. I hope we come across less threatening than law enforcement, and it's just a nice little bridge to connect with community members. Oftentimes, it confuses community members rather than intimidates community members. Um, so it's not so much like, "Why are you here?" It's kind of like, "Why are you here?" They're kind of confused why the health department are showing up. Um, and then, we come with a unique community partner network by virtue of our lived experience. So, when I was a kid, my dad taught me, hey, like life isn't what you know, it's who you know. And I use that tool today. So if I have an in somewhere, like I'm going to use that, um, to my advantage. I'm a selfish person at heart, and I want what Cillian wants, and what I want is to like break down silos and connect with people and help, build whatever sort of program for the person we're talking to, whatever they want it, I'll get them in wherever they want to go. And the way I get them in is by knowing people in there. Um, so yeah, we're always just finding ways to connect with people. And look, our perspective. helps us bring some insight to the difficulties of substance use that others without lived experience just don't have. Other people without lived experience have a ton of experience and knowledge that I don't have, but this is like a very niche area that we're able to focus on and benefit. Um, and this really helps us consider different angles of approach, different tactics to our work. And then, of course, operating a peer team is not without its drawbacks. While anybody is susceptible to vicarious trauma or compassion fatigue, people with lived experience may experience it at a greater risk for negative outcomes. So, you know, vicarious trauma and compassion, it can carry a lot of weight. It can be extraordinarily exhausting. Working in this field, doing this work with a harm reduction approach is a very patient game, right? Um, it's a lot of waiting, a lot of follow-ups, a lot of understanding that somebody might not be ready, and accepting that somebody might not be ready. All while doing that, we're seeing things that may force us to relive our past, um, and just, result in a lot of compassion fatigue. So I'm super grateful. We work on a fantastic team. We drive around in the car for 3, 4 hours at a time. So, dude, we get to know each other like big time. And we get to know like our families and what we're going through in life and our likes and dislikes outside of the job, right? Like they all know what makes Cillian tick. But we also get to connect with one another and really talk about like how things may have impacted us. I create a space for the folks that report to me. My supervisor creates a beautiful space for me to come and talk to him and, tell him what I'm annoyed at, or just express the weight that I've been feeling from the job. Um, I also lean heavily on the silver lining to compassion fatigue. I truly think there is a silver lining. And I witnessed this when I worked in a hospital to people who didn't experience compassion fatigue. And I've learned that like that's more of a red flag to me than somebody who does experience vicarious trauma or compassion fatigue. Um, we've leaned into doing a lot of conversations with nursing students and what they're going to experience when they go on the floor, and how nursing is just an extraordinarily draining and difficult field to work in. And I say the same thing to our staff as well. Like, dude, if you experience compassion fatigue, that just means you care, right? That means you're a good human being who is giving your all for the job. And there are probably going to be some days where you can't come in at 100%, and that's okay. It's okay to not be at 100%. Like I said, we go out in teams of two, and quite often I'll be going out with Lizette, and she'll be like, Cillian, I'm not there today. I'm at about 45%. Can you take the lead? And I'm like, you got it. And that allows her to do the job while not having to give 100%, you know? Um, and so compassion fatigue, like, dude, it's a part of life in my opinion. And like I say it to nursing, I say it to our staff all the time. Like it just shows that you care. Um, yeah, I'm leaning on the nursing part pretty hard because I've seen a lot of people go into it. They may experience some burnout, and then um, some old timers might say, well, maybe you're not cut out to be a nurse. And that can be harmful in and of itself to say to somebody who's, dreamed from a young age to be a nurse. I truly apologize if there are any nurses on board. I know so many great nurses that live in Louisville, and I love getting to work with them. But even they have said it as well. Like there is that culture within the floors of like maybe you're not cut out to be it, and it does happen as well in other walks of life, especially in the treatment and recovery field. People will think they're not cut out to do it. It can be frustrating to work in this field, but overall, my cup gets filled more than it does get drained. And when it does get drained, I have the support around me to refill it. Right, I'll come down off my soapbox for talking about compassion fatigue. Um, as a peer-led team, we don't have the ability to access, law enforcement databases, um, which can, create a barrier for us if we don't have address or if we have a bad address. And also because we don't have any law enforcement coming out in the field with us, there's a little bit of a missed opportunity for us to improve our relationships with our local police departments. We do partner pretty successfully with hospitals, treatment facilities, emergency services, behavioral health services, community centers, like anywhere at all where there may be a gap for a community member, we will find the resource that's in town and then connect them to it, and then also really try to like maintain that relationship with them, foster genuine, honest, compassionate relationships for the community partners and the residents. So again, when we go out in the field and meet Cillian and he's struggling with X, Y, and Z, like we know the person at the organization, so we can immediately we have like a direct line. I call Rachel. She knows who I am. She knows the only reason I'm calling her is because I'm out in the field and I want to connect a community member to her. And this really sets up a great trust system between not only between us and the community partner, or not only between us and the community member, but also between us and the community partner as well. We're always trying to tour treatment facilities. Um, Tour and treatment facility is funny. Like I'm not gonna I'll call a spade a spade. We'll tour treatment facilities. They know we're the health department. They always tell us what we need to, see and hear. They'll show us what we need to see. Um, but it's important for us to see how they operate to know if we think it's a reputable source to refer somebody to. So that situation will pop up if we respond to Cillian and he's like, I don't know where to go to treatment, where should I go? More often than not, people know where they want to go, or they know where they don't want to go, right? Because they've heard it through the grapevine of like, I don't want to go there. So again, we always ask a couple of questions to help navigate where people might want to go. What insurance? Have you got insurance? Do you want to do inpatient or outpatient? Do you want to stay in town? Do you want to get out of town? Like, what do you want your treatment recovery program to look like? We do a lot of Narcan trainings. We table a lot of events. We visit the local jail. If somebody overdoses at the jail, we'll visit them. We go to the dorms in the jail and talk to them about harm reduction and other resources. We've recently been invited into the hospital, which is a massive breakthrough, to where somebody came out of ICU. They're detoxing pretty hard, and the social worker at the jail, at the hospital, knows this person is going to leave and use again. And so she's like, hey, can you guys come in and talk to this person and just like bring them Narcan, talk about if they're going to use again, where they can go. So this is a new relationship that we're going to start really heavily working on to either continuously come into the hospital or just educate the social workers on like how to successfully refer people to harm reduction resources in town or at a larger scale in the state as well. Um, and then, yeah, I think I said we go to schools as well. That's been one of my favorite things to do. Look, we've had like 10, 11, 12 year olds appear on our list for having experienced an overdose. So we started reaching out to schools and just cold email and cold calling schools. A lot of them will say like, no, we don't, we don't have that issue here. But a lot of them have invited us into the schools and we have like real raw conversations about um, who we are, what we do as a team, what we're seeing in the streets, and our lived experience as well. And then I always tie it back to mental health. That's where it started for me when I was like 14. And so we talk to people about like self-esteem and self-worth, and how people think of themselves and how this can, later on factor into decisions we may make that have negative outcomes for ourselves. So really trying to implement more of a prevention approach to visiting schools for sure. I just love chatting with kids. I got three kids at home and they say, skibbity this and all that. So it's really funny, chatting with kids and throwing out some of those Sigma phrases, and just shooting the breeze with them. It's really funny. I enjoy it. So look, over the years, we've had tremendous growth and expansion. Like where the program is today is never where we thought it would be. We recently received an award from the state for like, I think it was like the best team category, which was a massive honor for us. Not something we ever set out to achieve, but just really nice to get recognition like that. We do a lot of community trainings. We also have like a lot of conversations on the why around the lock zone. So again, people will say, no, we don't have any of that issue here. So just educating them on like, where substance use is as far as opioid overdoses versus where it used to be 10 years ago and how far past we are of people experiencing an overdose due to, syringe usage. Um, Again, I mentioned before, we heavily leaned into the naloxone saturation program. There was one summer here, it was about 2 or 3 years ago. Dude, it was like the Wild West at the health department. We were just throwing so much Narcan out into the community. We couldn't keep track of it. We were trying to report it back to the state. Our numbers were way off, but the good people at the state just knew what we were doing, so they continued to feed us Narcan. It was a great time. Um, Drastically increased naloxone availability in our communities. Including getting two vending machines out into the community, and Nalox Box initiative. We got about 200 Nalox boxes out into the community. These are, small boxes that offer free Narcan anonymously. We also got about 22 out into local fire departments, and they're placed externally, which created 24/7 access at those locations. Again, I've mentioned we visit schools, colleges, local businesses, organizations. Basically, like any educational session tailored on our topic of expertise that anybody wants, we will create it for them. We will, the next one I'm working on is um, a local fire department who've been a super tough nut to crack. And said instead of a top-down approach, I'm going to try, getting my foot in the door and again getting what Cillian wants because I'm selfish, from a bottom-up approach and just trying to make those connections in any way possible. In the past, I've had conversations with like police departments and fire departments specifically, and once they hear my Irish accent, they really quickly want to get through the business of the phone call and then talk about my Irish brogue. And in my head, I'm like, oh, I got this. You know what I mean? Like, that's how I get in. And if that's how I got to get in with somebody, that's what I'm going to do as long as we can continue to do the work that we're doing, and reach the people that we're doing. So, Justin was super kind enough to tell me about a couple of what sounds like incredible programs, that already exist in Washington State. I know things are tight on the funding situation these days, but I think like any program, you'll all probably agree or understand, or I'm preaching to the choir. Like if you ever want to implement that like this, from the small time that we've been doing it, the best decision we've made is just getting people on the team that care. That's it. If you get people that care, like I can teach people how to do the background stuff. Like I don't think I can teach people how to genuinely, compassionately care about talking with these community members. So that's it for me in a nutshell. I think we got about 6 or 7 minutes left, maybe. But yeah, I hope this wasn't too drab or boring for you. And again, thanks for taking time out of your morning.
No, thank you for taking time out of your morning and presenting to us. That was outstanding. I think I felt a little, you made me laugh a couple times. I felt, when you're talking about the family members, I felt that in my heart, that's I've can imagine that situation. Or I don't know if I can or not, but it's got to be really difficult. Yeah, you had some really great questions coming in as well. So let's jump into those. The Washington Center for Nursing asks, in areas where there are more overdoses, are these more urban or rural? I assume they're talking about like the overdose rate, most likely.
Yeah, for sure. So when I can maybe try to go back and share again. But yeah, they're definitely more urban and low income neighborhoods. So higher rates of I can show you this slide here. Higher rates of crime, higher rates of substance use, all in these dark purple and lighter purple areas. We're up and down those areas every single day. Um, So we're currently in a situation where, if somebody out here in East Jefferson County called me and said, "Hey, I want to get one of those Nalox boxes," you know, I would say, I can't give you one right now because we're low on them, but I can give you Narcan. But we're really trying to focus on getting the lock boxes, Narcan access in these areas. This is where we really focus on community engagement, trying to get like, businesses, local organizations, community centers, libraries, hospitals, whatever, to you know to buy into our way of thinking. And if it takes years to do that, like I've slowly met with people in these areas to like have a cup of coffee and talk about this is my secret weapon as well. Talk about anything that's not the work we do, right? So connecting with people about family and about extracurricular activities. And I'm like, I'm exhausted. I had to bring the kids to cross country the other day. And then we're just people shooting the breeze. And then from there, a relationship grows, and then from there, we start to work together. So that's one avenue angle of approach. But yeah, definitely more urban areas. There's definitely less trust from community members to the government in those areas as well. So we have to work a little bit harder to like break down those barriers, and connect with people.
Super, thank you. And then we have from Megan, how do you keep the community supportive of your efforts? We hear a lot about how harm reduction and empathy are, quote, enabling. There's major pushback from the community for syringe exchange and Narcan distribution where this person lives. And I'm familiar with some of the stories from Washington, like there's community pushback even for just Narcan distribution in some places. What do you find works?
So look, if somebody doesn't want to do it, if we reach out to somebody and say, "Hey, would you be interested in distributing Narcan?" And they don't want to do it, like I'm not in that place in that moment to convince them. If they don't want to do it, I say that's okay. There are plenty of other locations in the area that do want to do it. Um, we respond to people and their homes. We show up unannounced. That's a point that I didn't bring up, and that's pretty important, right? Because if we say, "Hey, can we schedule a time to come and visit you?" They're going to be like, "No, don't come near my house at all. I don't want to hear from you." So because we show up unannounced, it's kind of like a surprise. And once we get a couple of sentences in, again, the conversation opens up. Um, we drive around in unmarked vehicles, we drive around in our personal cars, so we're pretty like incognito, right? Like people don't know who we are, why we're going to the door. We don't wear a uniform. We don't walk around promoting like, "Hey, we're practicing a harm reduction program over here." We just do it real subtly. And then as far as like naloxone distribution goes, other harm reduction practices, like if I respond to Justin and Justin wants to take supplies from me, we're allowed to give those supplies to Justin. Um, if Justin doesn't want the supplies from me, that's fine. The harm reduction approach is not to be like, "Well, I really think you need this Narcan," because again, that can be harmful. That can make Justin feel judged and stigmatized. There's a lot of non-community, or there's a lot of community non-buy-in. We still get to do our work as far as following up with people who experience overdose. Um, when we do come across people in situations, we do presentations across the city. um, I use these platforms as ways to get people to buy in. So we kind of call it a three or four pronged approach. I can't even remember at this stage, but I'll chat a little bit, and so will my coworkers, and then we'll talk about how we have lived experience. And that's kind of shifted the mindset of like, I didn't think that guy was going to be a person in recovery. Um, some people are stats and data people. I'm not. But when we bring stats and data and figures to a presentation, that can help shift people's mindset, right? And then the last piece is like that little bit of emotional manipulation that I like to use. And it's bringing the real stories that we hear from people to a stage, to a podium, and we're talking about it. So, I already know Justin is in headfirst in this world. But we even got to him by talking with family members. That's usually a good in to like, not even, it's just planting a seed of like helping somebody be open to shifting their mindset, is when we talk about friends and family members of people we've connected with, whether they've lost somebody or not, and how, the ripple effect of an overdose really spreads and it touches all the people around the person who overdosed and it spreads. And then at some point, I'm willing, if I were a gambling man, I would say that in the back of their head, they'd be like, oh, yeah, I do know so and so who knew this person who passed away from an overdose. So constant conversations, and sometimes creating those personal relationships with people will help break down those barriers. You know, if they read about harm reduction on a piece of paper, they might be like, nope, that's enabling. I don't want to do that. When they get to know me and the team members and other people who are doing this work, they're like, man, they're really good people, Like all they're really trying to do is see if everyone's doing okay. And that's it. But it takes a lot of work.
Sure, thank you. So this question comes from Brenda. I think you've answered a couple aspects of this already, so we're going to skip those. But the first one is an interesting question. Do you feel using drugs is a choice?
Do I feel using drugs is a choice? Yeah, for sure. I think it started out as a choice, and it's not always a choice. We talk about it in the recovery. Sorry, I'm doing hand gestures down here. You guys can't see it. After a point, for me, alcohol was the beginning and end for me. I definitely chose to do it. It was super fun, and then it got to a point where it wasn't fun anymore, and it was something I just had to do. Um, and this is over an 18-year period, and then. Um, it just got to the point where I couldn't function without it. There's a fantastic video called Film Builder. I'm not sure if you've seen it. If you Google or go onto YouTube and Film Builder, I think it's called Nuggets or something like that. I guarantee it'll come up. It's a short 5-minute video. I recommend watching that. For me, it's been such a powerful depiction of substance use. And it takes you from beginning to end. There's no words in it. And it's a beautiful, beautiful, beautiful video. But yeah, dude, it definitely changes. Like we deal with a lot of unhoused folks in our community. One of the terrible structures that's set up is like, hey, if you want to get, affordable housing or a housing voucher, you need to not be using substances. And the person is like, dude, substances is the only thing keeping me alive right now. Like, so yeah, I think it can be both. It's a tough one, it depends on where somebody might be at in their stage. Um, and we definitely see family members have like the tough love conversation with their loved ones, and we're able to come in and just be a different angle of approach of like, the tough love. They're having that conversation with you because they care about you and they love you, and to them you might be choosing to use substances. Within the person's mind, like it might not be a choice.
Sure, excellent. Um, I did just track down the video and it's in the chat for anyone that's interested.
Thank you.
Uh, Question from Ariel. What supports are provided for team members who are in recovery and also around this level of active use?
Could you repeat that?
Sure. What supports are provided for team members who are in recovery and also around this level of active use?
Yeah, yeah, yeah. Great question. There's not any concrete level of support, right? So it's kind of like to each team member their own. Um, I suppose the level of support that is there is constant communication. That's the best thing that I can do to support the team. That's the best thing that someone can do to support me. I had a conversation with a coworker last week. Not all of our team members are in recovery. Some are, some aren't. And this person in question isn't. But I knew something was off, right? And I constantly checking in with her. Hey, is there something going on in work? Is there something going on out of work? More often than not, I found that I have to check in with non-peers who are on the team than I do with peers, right? So we have these like t tough, difficult conversations, really hard, and we get back in the car, and I might let the dust settle for a minute. We'll check back in with one another. More often than not, peers are like, "Oh yeah, that's like dude, I used to live that. Like I totally get it, And they're not like triggered or traumatized by it. It's the non-peer support specialists that see that because they've never seen that world before. And they're like, oh my God, that person, you know, and that's where I really need to lean into supporting them, opening their mind to the harm reduction world, getting them connected to as many community partners as possible so they can see this more often, and just have them understand the mind of a substance user as best they can. Um, you know, we try to keep a pretty rigorous process on like hiring peers. So for me, like a rule of thumb, there's a window of how long I would like you to be in recovery, right? Before you get into this line of work, because it is heavy and it is government and there is a bunch of bureaucratic red tape that we have to deal with every single day. That's the part that peers struggle with, right? Because we didn't really hold down careers, you know, throughout our lives. So when we come in and it's like you have to fill out this form and send it to that, they're like, "What the is this?" You know. So walking them through that process is pretty funny. But yeah, like I've had a lot of people say like, "Hey, I want to do the work you do," and we're like, "That's awesome! Like, here's what you got to do it, right?" And we try to get them connected to volunteer services, other recovery employment services. And then once, you know, 6, 8, 12, 18 months pass, you know, we can chat again.
Wonderful. I think that brings us to a close. We have some praise for you in the chat. Thank you. Thank you for so much. This was an amazing presentation. Lots of accolades there. Do you have any closing thoughts you want to leave us with?
I did, and I forgot to bring it up. I was filling out the form when I first started filling out the application, and it had like two questions that you want to ask the members. The point I want to make is I'm pretty sure I asked at least one pretty silly question, and that was to highlight. It's kind of something me and the kids do, but it was to highlight the fact that, like, look, we work and live in this world that can be super, super tough. Like, it's vital for me to remember to have fun in my life, right? I didn't get sober to be dreary and bumming people out. So I can't remember what the question was. I think it might have been like, if you were an animal, what would you be, or something silly like that. But yeah, just try to have fun because, dude, life is short. Like, I love my life. I love my job. And most of the time we're driving around the car, we're just cutting up, like we're just like laughing about everything and anything. Because if we just live in this world, I fear that it just might consume me. So yeah, I love that everybody showed up for this. Like, the fact that you guys are coming to this means you're already doing the right thing. You care about the work you're doing. You care about the people you serve, and that's awesome. So just make sure, you smile, pet a dog today, or get some sunshine, or do whatever it is that makes you happy.
Excellent. Thank you so much. I'll certainly take that with me. Also, I think something that just stuck out to me was nobody is as hard on someone who uses drugs as the person who uses drugs, which I thought was a powerful sentiment that I'll probably repeat. And I appreciate that very much. Thank you so much for sharing about your program, sharing about your life, your expertise. It's perceived by an eager audience is when I see the great questions that we had, it shows that you're connecting. So thank you again so much. Just briefly, the next session starts at 11:45. It's trends in the illicit drug market. It should be fascinating. Lots of data updates from Haida. So look forward to seeing people there. And Cillian, thank you again for your work and for coming to our Overdose series and presenting. And I very much appreciate it. So thank you.
Absolutely. Thanks for having me. If anybody ever needs to reach out, I think I put my information on the PowerPoint. So, always feel free.
Great. Thank you.
Thanks, guys. Bye bye.